Thanks so much to the organizers. It's really exciting for me to be here at a hematology meeting, and I think more and more you're going to see cardiologists at hematology meetings and vice versa, because we're really even more entering into a multidisciplinary area. So here are my disclosures. And for this talk, what we're going to talk about are the three main complications of cardiac amyloidosis, which are very familiar to the group: heart failure, arrhythmias, both tachyarrhythmias and bradyarrhythmias, and conduction system disease, and sudden cardiac death, especially in the AL patients. And I have to tell you, all of these are very, very tough to manage. So this is really a hard talk. Most of the time when I speak about cardiac amyloidosis, it's to cardiologists trying to raise awareness and get an accurate diagnosis. But managing these complications is really challenging. And as this group knows, for AL amyloidosis, of course, the mainstay is treatment of the underlying disease. And as cardiologists, we play more of a supportive role, and very difficult at that. Now with TTR amyloid, we're in the advent of therapy, so we have the ability to really impact maybe even the development of heart failure in these patients. So very exciting, but still a very difficult topic. Now, one of my favorite things that I discuss with patients, and I thought as hematologists you might like to hear this too, is just highlighting ejection fraction. So remember that ejection fraction is a percentage. So I made these graphics, and they're actually online. We actually have a Mayo Clinic amyloid YouTube channel, believe it or not. We have about 13 videos on there, which include several on cardiac amyloid. So I use these with my patients to try to illustrate cardiac function, and I think it's helpful for hematologists too. So just remember that ejection fraction is the percentage of blood that's ejected with every heartbeat. But if the heart doesn't fill very well, as in amyloidosis, the ejection fraction can be normal or low normal, and really the cardiac output is significantly reduced. So just to highlight that the main issue with cardiac amyloidosis is a loss of elasticity of the heart. So the heart, after systole, should relax in diastole and be able to really truly suck blood into the heart. And that's why athletes can increase their cardiac output so much, because their hearts are so elastic. So the ejection fraction, if it's normal, that's not necessarily reassuring, and you all know that in cardiac amyloid. The stroke volume and the stroke volume index and cardiac output may be very severely impaired. In addition, the heart function is really very complex, and if you look at an echo report, you'll see about 100 different numbers. So we don't have a single number that tells us how the heart is doing. However, when you hear that heart failure is the inability of the heart to pump enough blood to meet the body's demands, then it makes sense that you hear ejection fraction is the percentage of blood pumped. It seems like ejection fraction would tell us the answer, but as you know, it doesn't. The other thing I want to highlight is that in amyloid patients, because the ventricle is small, even a small change in our measurement may lead to a relatively large change in ejection fraction, even in situations where there may not be a significant change in the overall heart function. So there's really more room for error in amyloid patients. So I must say, when I go in to see a patient, I usually have reviewed a lot of things in advance, their outside records. The nurse gives me some idea about their symptoms. I know their family history. I've looked at all the tests we've done. I've literally just looked at their echo. And I know the strain, I know the EE prime ratio, I know how the IVC looks, I know the estimated right ventricular systolic pressure, I know the wall thickness, I know if the right ventricular walls are thick, what the RV function is, and then the patient says, "What's my ejection fraction?" And I look like this really dumb doctor, because I go, let's see, what did we report it? And I literally just looked at it. So I make the case to you that EF is close to useless in amyloid. Now, that's a little exaggeration. We do want to know the ballpark. Is it 10 or 25%? Those really low EFs are obviously associated with poor outcomes. Is it 25 to 45, or is it more than 45%? So I just kind of caution you, that's the spiel that I give to the patients. And these minor changes in EF often don't mean a lot. One thing I've learned over the years of working with the hematologists a lot is that Hematologists love numbers. And their numbers are actually pretty darn accurate. And of course, what's one of your major diseases? It's anemia. You've got hemoglobin, hematocrit, all kinds of other ways. But you have everything you have is a count, right? So the hematologists appropriately have learned how to apply those numbers to cardiology, primarily with the biomarkers, which are very, very powerful. However, cardiologists love pictures. Now, with our pictures, sometimes we put numbers like ejection fraction, like strain, but they're really a lot more gray zone than you would think from those reports. In fact, even if you look at coronary disease, we say that the LAD stenosis is 80%. Different cardiologists look, no, really, it's probably only about 50%. So our numbers are really not as precise as yours. So I've thought this for quite a while, but recently I noticed I felt terrible that I missed Jeff's Journal Club. So those of you who aren't on Twitter should get on Twitter. There's so many fun things and informative things happening. But just last week, there was a Amyloidosis Journal Club. So I thought, let me go see what I missed. And here's what I saw when I tried to figure out the article. It's actually Dr. Mukhtar's article, by the way, so he needs to get on Twitter. And here's what I found from Vaishali. This is what I found when I wanted to see what happened at that journal club. I have no idea, but it proves my point that hematologists love numbers. I couldn't figure out anything from that from that tweet. So, but there are, if you're going to look at numbers, there are some numbers that probably might help you a little more with your amyloid patients that you don't think about. So stroke volume and stroke volume index are calculated on most echo reports. And the stroke volume is the actual volume of blood, not the percentage, but the volume that's ejected with every beat. Then the cardiac output, of course, is the stroke volume times the heart rate. So that's a pretty important number. And most of the time will be calculated, and then you can index the stroke volume for the patient's body surface area. So this is actually the stroke volume here. This is the amount of blood that was filled in diastole. And if we look at this animation, you'll see the heart filling with blood here. So here you're going to see the diastolic volume. Then, and we did this as kind of balls of blood to make sense for our patients. And then you see the actual amount that was ejected. And so this is the actual stroke volume right here. And then we can calculate the ejection fraction, and we do it by volumetric techniques and other techniques, but just showing you the difference between the stroke volume. And this would be an amyloid patient with a very small ventricular cavity. So you might have a reasonable ejection fraction, but a very low stroke volume. And Dr. Milani, who's in the audience, looked at the overall survival according to stroke volume index in patients with AL amyloidosis and noticed that the stroke volume index of less than 33 was a very good discriminator of prognosis. And this is independent of EF, of blood pressure, of biomarker stage, and even LV strain. It actually performed as well as LV strain, so in labs that don't have strain readily available, and there are some issues with reproducibility of strain as well. So it's a pretty simple predictor of outcome. But again, you have to make sure that it was done in an accurate manner, and there are some technical reasons. So really, I want you to take the whole echo in context or your whole cardiac evaluation in context, but this is one number that can help you. Another reason I mention it is, this is the reason it's so hard for us to manage patients with cardiac amyloid, because they have a low stroke volume usually, a fixed stroke volume, no ability to adapt. So heart failure is very difficult to manage, and arrhythmias are very difficult to manage. These patients are really literally the ones with significant cardiac involvement. They're walking on a tightrope. And if you have them right in the middle of the tightrope and you have everything balanced, they're not necessarily good, but they're kind of okay. But if anything tips them out of balance, they fall off that tightrope in a big hurry. And that's why it's so hard for us to manage these complications. So when we think about what we have, it's not that we're bad cardiologists. If your cardiologists aren't making a lot of progress with your patients, it's because it really is the toughest form of heart failure for us to treat. So obviously, the prime treatment is to stop amyloid production. For diuretics, there's a few tricks, and for most of us, we will use torsemide because the bioavailability and the consistent absorption is better in our patients. So that is something that switching to torsemide may often help you compared to furosemide. The aldosterone antagonists are very helpful in preventing hypokalemia and do provide some additional diuresis. So we really want to keep potassium above 4 whenever possible to help minimize arrhythmias. A kind of simple thing is using compression garments, because what I tell patients is we want to use every mechanical means to mobilize fluid and to try to minimize our diuretic dose because of some of the complications, especially in these patients who are prone to hypotension and renal disease. And then again, we have this tightrope of heart rate. So most of our amyloid patients, the ones that are pretty advanced, if anything, are going to need a little higher heart rate. So if you lower their heart rate to even what cardiologists are usually targeting, they may be in big trouble, especially if you do it in a way that's irreversible. So patients can suffer from both just a little bit of tachycardia or even a relatively small amount of bradycardia. And then you want to make sure you've treated sleep apnea and any other aggravating factors that might be making their heart failure worse. I do think cardiac rehab, especially recognizing that we're not going to push these patients real hard, but that's the importance of having monitoring and some light strength training, is helpful for our patients who are compensated enough to do so. And especially when we talk about the TTR amyloid patients who often do have a longer survival, the importance of not only aerobic but strength training can become quite evident. So we have a lot of studies in the heart failure world highlighting to us that heart failure doesn't just happen at the level of the heart. It's what's happening in the systemic vascular resistance and the periphery. And one of the things is metabolically, muscle is much better than fat. So for all of our patients, I really tell them that in the cardiology world, maybe we've emphasized aerobic exercise a little too much to the general public, and strength training is very helpful if done cautiously and with a low amount of resistance. So what I tell my patients is the heart really likes to pump to muscle, not flap. So I get them doing a little bit of strength training. Many of you know that especially AL patients, particularly early after the diagnosis, really do not do well with standard heart failure treatments. Beta blockers, ACE or ARB, and Entresto, and those are almost always contraindicated, again, especially early after the diagnosis. There might be a role in some of our very chronic patients that we actually do see chronic AL cardiomyopathy now, I'm happy to say, because of all your advances, and that might be a little bit different. But cardiologists will often start these on your patients because they're trying to do what the right thing is for heart failure. And of course, they get all those little warnings in the EMR. How come you didn't put the patient on ACE inhibitor, beta blocker? So just make sure you convince your cardiologist not to do that and just to check not applicable on that epic warning that they get. You do not uncommonly face patients with cardiac amyloid who have reduced ejection fraction, both AL and TTR. But again, the reverse remodeling that beta blockers and ACE-ARB inhibitors are so beneficial in other types of heart failure really don't apply to patients with an infiltrative cardiomyopathy, and especially beta blockers, particularly Coreg, because it has alpha blocking characteristics, is particularly difficult. What about circulatory support devices? So the role for these might expand as the devices improve. The key challenge is that most of these patients will need biventricular support. So a left ventricular assist device doesn't work very well with a small, thick heart. And that's because we put a cannula in the LV apex, and there is this suck down effect, it's called, where as the blood is being sucked out into the device, the thick ventricle literally just collapses around the cannula and obstructs flow. The right ventricle is often abnormal, so these patients usually need biventricular support. Organ transplant is an option in very highly selected patients. For most AL patients, most centers will require that the patients have primarily cardiac involvement and very limited extracardiac involvement. You'll see a range of which centers are willing to do AL patients, and you might see a little trend where they'll do some and then they stop doing them. The role, unfortunately, we're often diagnosing these patients too late, but for highly selected patients, organ transplant is a possibility, and especially ATTR patients are increasingly being diagnosed, especially the wild-type patients, in their 60s. And they are often, if they have advanced heart failure, they can be very good heart transplant candidates. So they usually have had very few other medical problems before they get amyloid. So here we'll talk about a patient, a 55-year-old, who noticed some palpitations while he was running. And he had not been on his program quite as much recently, so he thought maybe he was deconditioned. He had a stress test that was negative for ischemia, but he did have some non-sustained ventricular tachycardia on the stress test. About 6 months later, he still wasn't really feeling right, and he finally got an echo. He was diagnosed with non-obstructive hypertrophic cardiomyopathy. His EF was 65%. He was started on a beta blocker, and it was recommended that he get family screening and genetic testing. And he still wasn't really feeling too horrible, but he wasn't able to really run the way that he thought he should. So 9 months later, a new cardiologist came to town, took a look at the echo and said, I don't think that's hypertrophic cardiomyopathy. I think you may have amyloid. But for some reason, it took 2 more months to get a cardiac MRI. And that was poor quality and indeterminate for amyloid. Anybody know why it was indeterminate? Because one of the problems in amyloid is that the myocardium does not null with gadolinium. So it's was actually classic for amyloid because you really can't see the heart as well as you should because of that difficulty nulling. So then 13 months into this saga, he happens to go see a urologist because he had kidney stones back in the day. And the urologist says, you've got some proteinuria, you better see an internist. And then at 15 months, he gets a light chain assay. So I don't have to tell this crowd that this is way too long. It took him 17 months before he actually got diagnosed with AL, amyloidosis, with cardiac and renal involvement. And here you see the lambda. We have milligrams per deciliter, but 7.08 milligrams per deciliter, ratio 0.04. His troponin and NT-proBNP were both elevated, and he had significant proteinuria. So that was way too long. I didn't include biomarker staging for AL because I think you all know about it, but obviously this is a patient we would have wanted to pick him up back at the time of that first echo or even earlier. So during chemotherapy, he developed some heart failure. Now, he really did not have overt heart failure before, but his NT-proBNP went to almost 8,000. He had stem cell harvesting, and he developed some pulmonary edema, although he responded pretty quickly to diuretics. He developed atrial fibrillation with rapid ventricular response, and he happens to already be on anticoagulation due to a DVT. So here we'll use the audience response, and I wonder, now your cardiologist says that he needs a cardioversion, and so what are you going to recommend for this patient? So should we go ahead with the cardioversion? Should we do a TE-guided cardioversion? Should we do amiodarone followed by cardioversion? Or you're going to be honest and say you're not really sure what to do with this patient? I think we have very honest hematologists here. They're probably more honest than most cardiologists, would never admit that they are not sure of something. So, okay, so people are not really sure what we should do with this gentleman. And I mentioned that these atrial arrhythmias are so difficult. If you're going to do a cardioversion, which is not unreasonable for the first episode of atrial fibrillation, I'm going to make the case to you that I really think it's important for you to educate your cardiology colleagues that you need to do this with TEE guided. And here's a paper that we wrote about TE cardioversion in patients with cardiac amyloid. We've known for quite some time that patients with any type of amyloid, but especially AL, have a very high risk of intracardiac thrombus. Here you see a patient who died of a stroke who never had any documented atrial fibrillation. Those were the earlier studies from our institution and others. And we recently looked at our experience of patients who came for a TE cardioversion, and we found that almost 30% of them were canceled. Most of those were because they had an intracardiac thrombus. And of those patients, almost half were either on anticoagulation or had short duration of atrial fibrillation. Importantly, when we cardioverted them, 14% of patients had complications. And these were not minor complications. These were VT, VF, bradycardia requiring pacing, or a stroke. Now, one of my colleagues said, well, that's not a big deal. You guys are used to dealing with this. I'm like, no, no. When we do elective cardioversion, we are not expecting those things. And in fact, our controls had a 7% cancel rate, but most of those were because they spontaneously converted the sinus rhythm, and they had only very minor complications, usually self-limiting bradycardia. In addition, when we looked at these patients later, only 43% of the patients with cardiac amyloid had resolution of their thrombus at 6 months versus about 83% of the control. So we've seen this clinically, that once these patients develop a clot, many times the clot persists. It's probably not an actual failure of the anticoagulation, but it may be not only the degree of stasis of the atria, but also local factors in the atria and the fact that the patients have a tendency to be more hypercoagulable. So we've convinced cardiologists that they should do a TEE before they do a cardioversion in these patients. And if you look at Holter's, whether you have non-sustained ventricular tachycardia or atrial fibrillation in a group of patients who had Holter's is associated with adverse outcome. But if you looked at a routine group that we had that were undergoing stem cell, it really did not impact their peri-transplant mortality when adjusted for Mayo stage. So usually, I'm not a big fan of the routine Holters. It just makes me more nervous. But if you found AFib, you can give them anticoagulation cautiously, so that might be one role. So back to our patient. He had CyBorD chemotherapy, got a complete hematologic response at 9 months. He was definitely feeling better, working full time. But look at this, his NT-proBNP went to almost 8,000 after 2 cycles. 9 months, it was better. And actually now he's about 15 months after his initial treatment, and he's been off of treatment for 3 months because of his complete hematologic response. And his biomarkers are now less than they were at baseline. So he's starting to show some evidence of cardiac improvement, and he's actually eventually had some renal response. But just thinking about this patient highlights that there are cardiotoxicity of your drugs, and you know that. Jeff also talked about that. So it can be hard for us to know when the patient's getting worse. Is he truly getting worse? Do we have organ progression? Is it the chemotherapy? Is it the steroids? Is it the atrial fibrillation? And there's not an easy answer to that. But in this patient, once he's off of chemotherapy, he's clearly getting better. So when we think about these arrhythmias, they have a very narrow range of heart rate. Most of the time, you're not going to do an urgent or emergent cardioversion. And you should really think about the lesser of the evils. Beta blockers at low dose, we often have to use for atrial arrhythmias, but higher dose are problematic. And in the interest of time, I won't go into the whole digoxin controversy, except to say that it was mostly in vivo. Never any evidence for the TTR patients that it was bad. And probably at low dose, digoxin might be preferable to amiodarone. Amiodarone does have a black box warning. It has a lot of bad things that can go wrong with it. So I included, I'm going to go through this quickly in the interest of time, but I think you want to use the lowest amount of beta blocker. You can consider DIG for these atrial arrhythmias. Amiodarone, if you're just using it for rate control, is a complex medication, especially if you're going to transition the patient to long-term oral amiodarone. It's also really not that great at converting patients, even though the ICU doctors will always tell you we gave amiodarone to convert the patients. But if you look at the studies, it really doesn't have that high of a rate of conversion compared to placebo. And just remember, if you give amiodarone, especially orally, it's going to take months for you to get that amiodarone out of the patient's system. So these AL patients especially are at risk of thyroid disorders and other complications. ICD, just to highlight that in AL amyloid, most of you know that the studies have been mixed, but there actually was one prospective study, and notice that 7 of the patients died of pulseless electrical activity, previously called electromechanical dissociation. So we don't really know, except for that many patients, especially with AL, will die despite an ICD. We really don't have enough information to say that we should use those for primary prevention, but we might consider them for patients with unexplained syncope, and we do use them for secondary prevention. So I'm going to just close a little bit with TTR amyloid. Looks like I'm slightly over, so I'm going to talk a little faster. But just to let you know that wild-type TTR amyloid is everywhere. So we've known from autopsy series that as people get older, it's common, originally thought to be incidental. But now we see with carpal tunnel syndrome, when it's bilateral, men over 50, women over 60, this is really not an uncommon disease. HFpEF, 13% of patients may have wild-type TTR, and that's half women. One of the most shocking things that you'll hear is spinal stenosis. There have been studies showing 100% of patients with spinal stenosis have amyloid, and half of those may be wild-type TTR. Now, those are being confirmed in larger studies, but it is a lot of patients. So everybody really needs to know about this, not just cardiologists, but hematologists all need to know about TTR amyloid. And how can you miss it? Because the patient's going to come into your office looking like this. So if the patient looks way better than the echo, they have TTR amyloid. If the patient looks a lot worse than their echo, then they have AL amyloid. So I'm just, Jeff, do we have a few minutes to talk about PYP? Because I'm a bad person.
Absolutely.
I'm running a little
late.
late.
A few extra minutes built in. So
Good. I'm not going to get the hook. So PYP scanning is really an important new tool, but it raises some also significant concerns. It's been a revival of nuclear cardiology. So technetium pyrophosphate lights up basically in the hearts of patients with amyloid, especially TTR amyloid. But one of the challenges that we've had is that some people have missed the memo, cardiologists especially, that you have to exclude AL amyloid when you're doing a technetium pyrophosphate scan. And you also have to make sure that the uptake is actually in the myocardium, not just in the blood pool. So this is what you would see on a SPECT image. So this is a planar imaging, so you see uptake on the left side of the chest, but that could be bone, blood pool, something else. You really want to see, is it actually in the myocardium? And why is that so important? Because as you all know, now we have tafamidis to treat TTR amyloid with a 30% reduction in all-cause mortality. And the number to treat is really very, very reasonable. So this is an important new drug, and you know that we also, you're going to hear about silencers and other options, but for cardiac right now, the drug that's approved is tafamidis. There are other silencers, and so I just, other stabilizers, so I just highlight that diflunisal is also a stabilizer, of course, and AG10 is in clinical trials. But back to some of the issues with PYP, there are some perils, and I'm just going to show you three really quick patients. Here's a 66-year-old who had dyspnea and a renal infarct. Echo and MRI suggested amyloid. His PYP was strongly positive with SPECT uptake. He started tafamidis, but he never even had free light chains. So he had markedly elevated free light chains, a lambda monoclonal protein, and the cardiologist ordered a serum protein electrophoresis. He might have even ordered it with immunofixation, but many labs only do the immunofixation as a reflex, or it just doesn't get ordered. So this is a really scary thing. This patient is now on chemotherapy, and fortunately he is responding, but he had several months delay. Here's another patient I just saw who had a dilated ventricle. His walls really weren't that thick. He had a bicuspid aortic valve with aortic regurgitation. PYP was positive, but it turns out he has a flail aortic valve, a torn leaflet of his aortic valve. And it's just planar positive because he has a big left ventricle with aortic regurgitation. So the blood is going backwards, so you're going to have more technetium pyrophosphate hanging around there. So this is another planar positive, SPECT negative patient. And then we just saw a patient referred for transplant that somebody decided to put on tafamidis, and it's just a big heart with blood pool uptake. So these are three patients. I saw two last week, three within the last couple months. This is just me, my little experience, and this is how much that would cost. So major problem. So PYP really is a great test. I don't want you to think it's not, but know that it was done in patients with a high pretest probability of having amyloid, and that's what led to our consensus document. Patients are really supposed to have typical echo and or MRI features of amyloid and heart failure in order to use PYP and the absence of a monoclonal protein. So make sure that your center is doing SPECT CT. Be careful of the planar imaging. I think we should really make that no longer acceptable. And make sure that your cardiologists know how to screen for AL amyloid. There are a few other causes of uptake, plaquenil toxicity, renal failure, myocardial infarction. So I don't think we need to panic yet, but this is probably the most scary thing I've seen in the last couple of months. So managing complications, the key, of course, is going to be earlier diagnosis and treatment. Worsening heart failure in an AL patient might actually be treatment toxicity, and increase in the biomarkers doesn't always mean that the heart got worse. I think I hopefully have convinced you there's a high risk of intracardiac thrombus, so if somebody's going to cardiovert your patient, make sure that they have a TE first. Make sure that everyone knows how to use PYP, and more than ever, now we're really going to need this multidisciplinary team to make sure we have accurate diagnosis and management. So you're all going to be seeing more amyloid because the cardiologists, as they look for TTR, are going to find more AL, and everybody in this room is going to be busy. So thanks very much for your attention.